cancer.
My
Over to
talk
you.
will be short and crisp, hopefully, and I will share with you my experience with orbital rhabdomyosarcoma, and this is the commonest primary malignant orbital tumor in children and arising from primitive mesenchymal cells, skeletal muscles. It could be embryonal or alveolar. Embryonal is less aggressive than the alveolar and requires prompt treatment. It has a very potential for local invasion and metastasis. And there are two age groups usually between 2 and 5 years and 15 and 19 years, but can occur at any age. There is no sex predilection, is slightly more in males, and it's about 10% of all rhabdomyosarcoma cases, 4% of children with with orbital tumors, and so mainly superior orbit, and may also arise extraocular muscles and eyelid. See this patient? He's a 5 years old, short history for 2 weeks and non-specific symptoms. She has, as you see, slight proptosis, epiphora, with watery eyes in her left eye, and see the difference now. I mean, like, when she lies down and so forth. And actually, she had the neuroimaging showed that there's a space occupying lesion in the orbit is large, and we did orbitotomy at that time, and we were lucky that that electron microscopy were next door, and it shows the rhabdomyosarcoma. At that time, we didn't have biomarkers and so forth. So that's a long way. Maybe now 25 years back, this case. And orbital rhabdomyosarcoma is the most common primary orbital malignancy among children. And afterwards, she was referred to oncology, and she was treated by chemotherapy. And she has her chemotherapy. She lost her hair, of course, and this is the follow-up. She came later, and with this dimple kind of where the site of the drain 4 years back, and 16 years follow-up also, and she went to the university. So you can really save these eyes if you really diagnose them early. And a lot of cases I have been involved with, but now what I want to tell you that it is not actually the biopsy. You want to diagnose patient, take biopsy, but actually the people are after debulking. You remove as much as possible from the tumor. It will reduce the burden for the chemotherapy. This is very important. And this is the main snag. Facial surgery is not biopsy. It is biopsy is not the right word, and it is debulking. It's very important for chemotherapy. And surgical reduction of the tumor is important for better outcome in these cases. And fewer than half of these patients present with pain, rapidly progressive proptosis, and so forth. And also we had another case that came from Sudan, actually with the eyelid proved to be recurrent rhabdomyosarcoma. We did kind of glabellar skin flap for her. And rapidly progressive proptosis, most common sign, often unilateral, eyelid swelling, ptosis, chemosis, diplopia or restricted eye movements if it's infiltrating, pain, loss of vision, sometimes very late. We don't wait for this. Imaging is very important. MRI is a gold standard with heterogeneous mass, iso-intense in T1 and hyper-intense in T2 with contrast enhancement. And you want to do CT, positron emission tomography to see whether there is a metastasis or not. So biopsy is not the definitive diagnosis. So it only helps in history. Now histoimmunochemistry people are doing, not lucky as electron microscopy is not available for, but I was to work at the university, and he had this, the electron microscopy was next door, so we did, and that time. Staging for core, now there is group 1, group 2. Group 1 is localized, completely resected. Group 2, microscopic residual disease, and group 3 is gross residual disease, and group 4, metastasis. So the case needs multidisciplinary approach. It's not only the surgeon, not the oculoplastic, not the ophthalmologist, but it needs a chemotherapy. And usually the chemotherapy is vincristine, actomycin, cyclophosphamide, and so forth. Or alternative, you might use vincristine and irinotecan as a low risk cases. The duration for 12 and 42 weeks, depending for treatment. Different is chemotherapy now, and radiation for cases with recurrence or alveolar histopathology. The role of surgery is limited, biopsy and debulking, as I told you, and the follow-up of this patient is for three. Some of them I have been following for the last 20 years now. Orbital rhabdomyosarcoma, it has subgroups. That's my conclusion. Actually, is that you should be aggressive in dealing with it, and early diagnosis, chemotherapy, and is the right treatment. Thank you for listening.
Thank you, Dr. Mahmoud. Very inspiring. I think the key of rhabdomyosarcoma in the orbit is that you have a very high index of suspicion, rapidly progressive painless proptosis in the age group, and the key for success is the immediate oncology intervention after excising the mass. So once we debulk, there is this resistance among pediatric oncologists to wait until healing happens, healing occurs. So once you disturb the tumor, chemotherapy has to be immediately initiated. And this makes a huge difference in management. So, and it kind of locally controls the disease as well.
I am amateur oncologist, but Dr. Ihab Saad and Fairuz PM is our expert in ophthalmic oncology.
I'm talking about the cooperation with the general oncologist, because they wait until healing happens, and this is where the complications happen as well.
Yes.
Dr. Mahmoud, excellent presentation. Such an elaborate topic, so concise that one key point that I would like to highlight as a practicing ocular oncologist is, as you said, it's not biopsy, it is debulking. And I would add another word in front of debulking, maximum debulking. Because when you showed the protocol, it's like, if you have completely resected, it's definitely an improved prognosis when compared to just a biopsy in that. And I think as a general ophthalmologist, sometimes you might come through these cases. So you have to keep in mind, it's just not taking an incision biopsy, but maximum debulking of these lesions.
I may add maximum non-mutilizing debulking. So save the muscles, save the eyes, save the nerves as much as you can. Remove as much tissue, abnormal tissue as you can, because this enhances and increases the success of chemotherapy and radiotherapy after that. And you mentioned also the rhabdomyosarcoma study, 2 international studies, European and American, and they have their differences. I think we have to conclude. We'll take a quick picture with the presenter here, and there is the group photo now outside, and Jum'ah prayer is here as well, those of you who want to go there as well.
Thank you so much.
Santosh
is not here.
Thank you so much for joining us.
Please gather for a group photo.